So today's class is about abnormal uterine function. So before knowing about the abnormal uterine function, let us just know what exactly is the normal uterine function. Okay, so why is this normal uterine function necessary? The normal uterine function is so for the normal labor to happen, we need good adequate uterine contractions, and power and passage is very important. Okay, so normal labor is characterized by coordinated uterine actions. Okay, how is this? When do you call that the uterine actions are coordinated? So the uterine actions are coordinated when you have adequate good uterine contractions which are coming at regular intervals with a gradually increasing frequency, and it will be associated with the effacement of the cervix and dilatation of the cervix. Along with it, there will be descent of the presenting part also. So when do you call that the for a normal uterine this thing, what is it that is needed? So you should have the polarity of the uterus. That is what happens normally. Your upper pole will contract. That is your fundal portion contracts. Your lower pole, that is your lower uterine segment, usually relaxes. Why does this happen? You are having two pacemakers at the level of the fundus of the uterus, that is at the level of the cornu. Okay, so cornu will be producing the electrical this thing. You have the reflexes which will start giving the commands for the uterus to contract. So the fundal region will have the maximum intensity of the uterine contractions, and then as it goes down gradually towards the lower uterine segment and towards the cervix, the intensity or the pressure of the uterine contraction reduces. So normally the uterine contraction pressure will be around initially in the, say for example, in the first phase or the first stage of labor, the uterine contractions will hardly measure around 15 to 25 mm of Hg. And as it progresses to the active phase, from latent phase, as the labor advances to active phase, the uterine contraction pressure increases and reaches to a maximum of 50 to 80 mm of Hg. So in the fundus, when you measure the pressure of the uterus, it will measure around 50 to 80 mm of Hg, whereas in the lower uterine segment or at the cervix, the pressure would have gradually reduced it to 15 to 25 mm of Hg. So what is the benefit of this polarity of the uterus? So it is your upper segment will contract, and your lower segment will be gradually the pressure reduces, and as a result of the pull, the lower uterine segment will be taken up. Okay, that is how the effacement or the shortening of the cervix happens. And with the descent, when the uterus contracts, the baby will be pushed down. Whenever the baby is being pushed down because of the ball valve mechanism, and also because of the membranes around the fluid filled membranes also acts like a ball valve mechanism and helps in dilatation of your cervix. The upper part is pushing the baby down and the cervix is getting dilated because of the contraction. Also the lower uterine segment is getting, what happens, your lower uterine segment is going to get, it will be taken up and effacement happens, shortening of the cervix takes place and dilatation happens. So this is how there will be progress. Okay. So now we all know that you are having the So I've already explained you regarding the basal tone, the peak pressure. When do you call that the lady is having adequate uterine contraction? So this is like when the lady is having a good in a period of 10 minutes. In a period of 10 minutes, the lady will have 3 contractions. That is, per this thing she'll have 1 contraction, each lasting for around 45 to 50 seconds. So in a period of 10 minutes, the lady will be having 3 to 4 such contractions, each having a peak pressure of 60 to 80 mm of Hg and each lasting for 45 to 60 seconds. Then you call that the lady is having good adequate uterine contractions. Okay, and this is very essential for the normal progress of the labor. So for the labor to be normal, you should have 3 parameters, that is your power, passage and the passenger. So now your power is adequate. The passage is your pelvic cavity. The pelvic cavity should be adequate enough to push the fetus down, and your passenger should be of the appropriate weight so that you are going to have the normal labor. So whenever there is any incoordination between any of these things, okay, so you're going to have you're going to have a difficulty either at the level of the power or at the level of the pressure. Then only you're going to have the abnormal uterine contractions. Okay, so let us get to know. So normally I have already told you about the uterine contractions, dilatation and all those things. So how will the cervix dilate in case of a primigravida? In case of a primigravida, the dilatation will be 1 centimeter per hour in case of a nulliparous women, whereas in case of a multiparous women, what happens? The dilatation will be much faster. And what is the difference between primigravida and a multigravida? In case of a primigravida, the effacement happens much earlier, that is 2 weeks earlier to her expected date of delivery. That is, there will be shortening of the cervix. Probably this is because of certain basal, that is your Braxton Hicks contraction increases more as the pregnancy advances towards term. As a result of this, there will be some amount of shortening of a cervix in case of a primigravida. But what happens in case of a multigravida? This is not the thing that happens. Effacement and dilatation happens simultaneously. So next, coming to how will you assess the uterine contraction? So when you palpate the abdomen, you feel that the uterus is very well contracted. The fundal region will be hard in consistency. You will not be able to indent your finger, but it will be a intermittent one. The uterus will contract and completely relax. So you should have a uterine contraction associated with relaxation in a period of 10 minutes to call that this is a normal uterine activity. Okay, so this is by doing an abdominal palpation, you will get to know whether the lady is is she having a good, adequate, coordinated contraction. Then second thing is you can also measure the pressure by using tocodynamometer. Tocodynamometer is an external transducer. I think all of you would have seen the NST machine where you have a tocodynamometer and you have one more transducer which will measure the fetal heart rate. Okay, so when you place the tocodynamometer, it will show you what is the pressure. So ideally the uterine pressure is either measured by using millimeters of mercury or it is measured using Montevideo units, or you can just place one intrauterine pressure catheter to know the what is exactly the pressure you will get to know. Okay, so now coming to the abnormal uterine action. So if there is any deviation from the normal pattern, what I have explained to you is designated as disordered or abnormal or incoordinate uterine contractions. So any deviation from the normal pattern, say for example, now you are having a lady who was like entered into labor. She was having adequate good contractions and labor was progressing, but there was prolongation, as a result of which the lady starts to have a reduction in her contractions. The pain absolutely disappears, uterus will not contract at all. Then also you call that it is an abnormal uterine action. Or suddenly the uterus may start acting very much like there can be a continuous contraction without a relaxation. Then also it is abnormal. Or the uterus will contract, relax, contract, relax. In a period of 10 minutes, you may have 5 to 6 such contractions. Then also you call that it is an abnormal uterine action. So incoordinate action means any deviation from the normal pattern, you consider that to be an abnormal contraction. So what is the incidence of this abnormal contraction? In case of a nulliparous women or in case of a primigravida, the incidence is around 25%. So what is the incidence in case of multiparous women? In multiparous women, it is around 10%. Okay. So next, coming to the classification of this abnormal uterine activity. Abnormal uterine activity is classified into inefficient activity and an over efficient activity. So in inefficient activity, you have three different types. It can be a hypoactive state or the uterus may go in for inertia. Next will be cervical dystocia. The last one in this ineffective, that is inefficient activity, it can be a hyperactive incoordinated state. So here the uterus will be having an inefficient activity. It will not be a proper. I'm sorry, what happened? I'll just continue with the presentation. Are you people able to see? Hello? Hello?